everyone, and welcome to a conversation with Cognition Therapeutics. Before we begin, I want to remind our viewers and listeners about our work here at Cognition Therapeutics. Our work focuses on neurodegenerative diseases, age-related diseases such as Alzheimer's disease, dementia with Lewy bodies, and age-related dry macular degeneration. These affect millions of people every day. Our approach to these conditions is to leverage our expertise in sigma-2 receptor biology and to take our lead program, a small molecule, CT1812, and put it in multiple clinical trials. Today, we're talking with Dr. Anthony Caggiano, who is our Chief Medical Officer at Cognition, as well as Dr. Jim Galvin. Jim is the Director of the Comprehensive Center for Brain Health at the University of Miami Miller School of Medicine, and he is the Principal Investigator on our SHIMMER trial for patients who have dementia with Lewy bodies. Tony and Jim, over to you.
Dr. Galvin, thanks for joining us today to talk a little bit about dementia with Lewy bodies. Can you start by telling us in layperson's terms, what is dementia with Lewy bodies?
Sure. So dementia with Lewy bodies, or DLB, is the second most common cause of dementia or memory disturbances in older adults after Alzheimer's disease. It's estimated there are roughly 1.4 million Americans who are living with dementia with Lewy bodies. Just put that in perspective. There are about 1 million people with multiple sclerosis. There are about 800,000 people who have a stroke. There are 250,000 people with muscular dystrophy, 12,000 people with amyotrophic lateral sclerosis, or ALS. Yet there are approved treatments for all of these diseases. And while you don't want to compare one disease to another, the fact is there's a huge unmet need for people. And if we don't find something that's more effective, the number of cases are estimated to triple in the next generation. DLB is a progressive degenerative disease. It affects multiple domains. So people have trouble with their memory and thinking abilities. Most people have some subtle signs of Parkinsonism. So they move slower, stiffer. They have problems with their balance. They experience something called fluctuations. So these are spontaneous changes in the level of alertness or attention. They experience visual hallucinations, seeing things that aren't there, typically described as little people or furry animals. And they can have an unusual phenomenon called REM sleep behavior disorder. And so this is acting out one's dreams. And this constellation of symptoms is very unique and distinguishes DLB from other brain diseases such as Alzheimer's disease or Parkinson's disease.
Great. So we've heard from others that it's often somewhat of a challenge to get to a diagnosis of DLB. Can you tell us a little bit about the path that patients take and how long it takes to end up with that diagnosis?
That's a great question. So we interviewed over 1,000 caregivers to try to get a sense of what the diagnostic experience was. For the average patient, they see 2 to 3 doctors over 5 to 7 visits over 18 months in order to establish a diagnosis. When people are diagnosed, about half the time, they're diagnosed with either Alzheimer's or Parkinson's disease, which technically isn't the correct diagnosis, but may reflect what the patient and the family was complaining about. The other half of the time is the real concern. So about 25% of the time, people are diagnosed with a primary psychiatric disease, a geriatric schizophrenia or a geriatric bipolar disease, which one, for the most part, doesn't really exist, and two, puts that person at risk of being exposed to a lot of medications that can cause harm. And then the other 25% are not given any diagnosis. I would say anecdotally, patients are confused. They know that something's wrong. They're not sure what that is. The family is looking for answers, and often they have to search through multiple doctors until they finally get to someone who could recognize DLB, make the diagnosis, and then begin to think about what they would do to treat, even in the limited options we currently have now.
So let's turn a little bit to that unmet medical need. Why do you think that is? Perhaps tell us a little bit about the known biology and what's unknown about dementia with Lewy bodies.
So we know a little bit about the Lewy body itself. So that's the pathology or the change in the brain. So this is a clump of protein that deposits in the brain of people with Parkinson's disease and dementia with Lewy bodies. Although it was originally described in the early 1900s by Dr. Lewy, we really didn't know much about what made the building blocks of Lewy bodies until fairly recently. So in the 1990s, there was a description of a protein called alpha-synuclein. So this is a protein that's involved in cell-to-cell communication. We don't know what its exact role is, but that seems to be the role. For reasons that are not entirely known, in some individuals, this normal form of synuclein, which is a soluble protein, maintains itself in solution, starts to clump together. And as it clumps, it starts to form fibrillar forms, and then it ultimately forms a Lewy body, which is a clump of protein inside the cell. It also forms what we call Lewy neurites. These are abnormal clumps of protein in the cell projections, so how one cell talks to each other. So ultimately what you have is almost like a dying back phenomenon, right? So the cells' connections start to die back, the cells stop being able to communicate with each other, and ultimately this leads to the clinical syndrome of the dementia and the movement changes and the visual hallucinations and the REM sleep disorder.
So let's turn a little bit from the biology now to how perhaps we can approach and treat the disease. Obviously, cognition is using a molecule to go after the sigma-2 receptor, but tell us a little bit about other things you see in the field and what avenues excite you when you see potential for developing therapeutics.
I think the real interesting, as we understand more and more about the biology, we really see that targeting synuclein aggregation may be the key to developing therapies that are going to be effective and disease modifying. And so most of the therapies that are out there are trying to do one of two things: either interfere with synuclein aggregation in some way, or it blocks the pathology of this abnormal synuclein, and that allows the body potentially to then clear it because it's not binding to a cell. And that would be an example of looking at the sigma-2 receptor, is blocking the binding site where the oligomeric or clumped synuclein binds to the cell and triggers the pathology.
So assuming that there's a drug that has good effect, what does a good trial look like, and what results would be a win for the field?
If we can demonstrate a win, it would be a drug that slows down cognitive change, that translates into improving overall global functioning. Does the drug affect not only memory and thinking, but does it impact that everyday global functioning? Does it affect their mood, their behavior, their attention, their movement, their sleep, or other features like constipation and dizziness that are so common in the disease? So it'll really help us understand globally how the medication may affect the patient. And that's based on good preclinical science, good development of a trial design, picking the right outcomes, engaging experts in the field, and then modifying tools to make sure we can capture DLB specific symptoms.
Thank you all for tuning into this discussion about dementia with Lewy bodies. DLB awareness is crucial to our ability to enroll patients in trials, and that's what will allow us to make advances in this disease area. Jim, Tony, thank you for your insights and for your time today, and we look forward to further conversations.